So in the lab, we will discuss the inflammatory lesions along with tumors of the blood vessels and of the heart. So lecture will be more or less confined with inflammatory lesions of the blood vessels, and this is a very, very important topic because you will be hearing new names in it. New names you will be hearing, and there are many, many types of inflammation of the blood vessels. So what is the inflammation of the blood vessels called? Vasculitis. Itis means the inflammation, and vascular means referring to the blood vessels. So vasculitis is a general term for vessel wall inflammation. Why you are late? Why you are late? How the vessel walls will get inflammation? There are two main mechanisms. One is direct invasion of the vascular wall by the infectious pathogens. The bacteria, fungi, they come and attack the vessel wall directly. Second is by immune mediated mechanisms. It may be antibodies or it may be immune complexes. Okay? So these are the two main mechanisms. Besides these, you can have the physical agents, the chemical agents. They can also directly, like mechanical trauma, there are chemical agents, toxins are there, and radiations are there. So these are the three main things which you will be seeing. Immune mediated inflammation, immune complexes, antibody, direct vascular invasion by infections, and physical and chemical injuries. But here is a question for you. Infections can also induce immune mediated vasculitis. Anybody knows how? We say one is direct vascular invasion. Another is, infections can also induce immune mediated vasculitis. How? One is saying cross-reacting antibodies. Very good. Another one?
Same structure. Same structure.
That is the cross-reacting.
Which recurrent a lot of blood cells released in different cytokines.
One is cross-reacting antibodies. Organism is directly. Direct invasion is, organism, by the organism. But how it...
Maybe it can increase the immune system, which lead to...
One is actually good. Which one he is talking about? The cross-reacting antibodies. Your body forms the antibodies, they attack the bacteria as well as the blood vessels. Okay. Another is antibodies are formed and the immune complexes are formed. And these immune complexes deposit in the blood vessels.
Yes,
okay. So these are the two things. So infections can directly attack the blood vessels and also through the formation of the antibodies. Okay. So two mechanisms are there. Why it is important when you are diagnosing a patient, you have to understand whether it is immune mediated or infectious related. Why? Why it is important to distinguish between the two? Anybody? Treatment. How?
Cortisone or antibiotic.
Very good. And in infections, you will give the antibiotic. So the treatment will be very, very effective. The antibiotics will kill the bacteria. But if you think it is immune mediated and you give the antibiotics, they will not be effective. Okay? So the thing is, in infections, you have to give the antibiotics. But if you give the immunosuppression, what will happen? It will flare up. So reverse will happen. So it should not. That is why you have to distinguish between the two. You got it or not? In infections, the treatment is antibiotics. Okay. So you will not give. In immune mediated, you have to suppress the inflammation. You have to give immunosuppression, immunosuppressive drugs. So if you give the immunosuppressive in the infections, it will be counterproductive. Okay. The vessel wall inflammation will flare up and more symptoms and signs will be there. So with this background, we will move forward. Classification. There are many different classifications which have been attempted with some success. So 20 different classification categories. We will not discuss any classification, or only one. So we are saying according to the vessel size. This is mainly we will be taking into account the large vessel vasculitis. Okay, we have the two. Then we have the medium vessel vasculitis, again 2, and small vessel vasculitis 3. Okay, according to this we will adjust it. I will show you the diagram. So depending upon which vessels are involved, we say it is large vessel, medium vessel vasculitis or small vessel vasculitis. Then role of the immune complexes. Whether it is immune mediated or not, whether immune complexes are required or not. Then role of the specific autoantibodies. Whether it is mediated by the immune complexes or whether it is mediated by the autoantibodies. There is one called when the autoantibody directly attacks the blood vessel. Another is, it is first of all immune complex is formed and then it attacks the blood vessel. Then some of the vasculites, they have the granuloma formation. So we call them as granulomatous vasculitis. Others are non-granulomatous. Then tropism, according to which tissue is involved. Tropism, tissue tropism and population demographics. Some of the vasculites are more common in some populations. So according to that, these are some of the classifications which we can do. What is the problem? Now pin drop silence, please. Because if somebody moves his head, so it makes a problem for me. So this is the diagram from Robin's pathology. You can see the large vessel vasculitis. Just concentrate. Aorta. And if I find anybody, it will be detrimental for the whole class. I will punish whole class and we will make it a point we will not give hospital. So keep this thing in mind. I am very serious regarding this. Very serious. I should not find anybody talking now.
سمعت يا شباب؟ ما في وصفات كذا.
They can understand this much English. No problem. You need not to tell them. Don't be too smart. So large vessel vasculitis involve the aorta and the great arteries, big arteries mostly, large vessels. So in it you have the two types, giant cell arterites, and it is also known as temporal arterites. Another is Takayasu's arterites. So these are the two varieties. Clear? Two. These are large vessels. Then comes the middle vessel, medium vessel vasculitis. We have again two types. One is polyarteritis nodosa, another is Kawasaki disease. Clear? So these two are granulomatous, the large vessel. We also call them as granulomatous vasculitis. The medium vessel vasculitis, like polyarteritis nodosa, is mediated by the immune complexes. And Kawasaki disease is mediated by the anti-endothelial cell antibodies. So these are the different things. Granulomatous, immune complex, anti-endothelial cell antibodies. So, but there is a problem here. There is a problem. The large vessel vasculitis are involving the medium vessels also. So look, it starts from here, but there is an overlap.
Okay.
You got it?
Yes.
Then medium vessel vasculitis, it involves the medium vessels, but it involves to some extent the smaller vessels also. Then the smaller vessels go here also. So there is an overlap. But there is predominant involvement. That is what we need. Here predominantly large vessels, predominantly medium vessels, predominantly small vessels. No, if we go to the small vessels, so you have the three types. One is microscopic polyangiitis. Second is Wegener's granulomatosis. Third is Churg-Strauss syndrome. Okay? Churg-Strauss syndrome. What is the difference between the three? So at the end, when you have the exam very near, go for this diagram. This diagram will tell you very quickly where it fits and what is the pathogenesis. Very quickly. Pathogenesis is also very clear from this one. So this diagram is very important. So vasculitis without asthma or granulomas. Without asthma, without granuloma. It is the microscopic polyangiitis. Then, if the granulomas are there, no asthma, it is Wegener's. Then you find asthma also and granuloma also. It is the Churg-Strauss syndrome. So this, we are talking about the small vessel vasculitis. Here, you do not find anything. No asthma, no granuloma. Here, granuloma is there. Here, asthma along with the granuloma and the eosinophilia. So this is how you differentiate between the three. Now, what are the most common immune complex mediated vasculitis? SLE. You know, SLE is a type 3 hypersensitivity. Immune complexes are involved.
Yep.
So SLE vasculitis is also immune mediated. immune complex mediated, IgA vasculites. So IgA vasculites, for example, in phenoxylamine purpura, this is also mediated by the immune complexes which contain IgA antibody. Then cryoglobulin. So this is cryoglobulin vasculites. The others are like Goodpasture syndrome. These can also be mediated by the formation of the immune complexes. For immune complexes, you need to have the antibody first. Antibody is there, only then it will combine with the antigen. And whether this antigen will be circulating or in situ. Circulating, it will circulate and then deposit. In situ, it is already present in the vessel wall and the antibody attacks it. Is it clear?
Yes.
So large vessel, medium vessel and small vessel. Clear? No, we will go, broadly speaking, we divide the vasculites into two parts. One is non-infectious vasculites, another is infectious vasculites. Non-infectious and infectious. So how do you see what are the immunological mechanisms which are responsible? The whole we will be discussing mostly on this non-infectious. Only the last slide will be on infectious. So keep this in mind.
Okay.
Last slide infectious. Rest of the slides are on the non-infectious vasculites. So what are the immune mechanisms which are responsible? So non-infectious vasculites, the immune mechanisms are, first, non-infectious means related to the immune system now.
Yes.
Clear? So immune complex deposition, one. Antigen antibody complexes are formed and they attack the vessel wall. Second is antibodies. Anti-neutrophilic cytoplasmic antibodies. We call them as ANCAs. ANCA. Okay? ANCAs. These anti-neutrophilic cytoplasmic antibodies, they attack the vessel wall. Two. Third, anti-endothelial cell antibodies, like in Kawasaki disease. These are directly against the endothelial cells. So these antibodies come and attack the endothelial cell. So we call them as anti-endothelial cell antibodies. Then sometimes we have the autoreactive T cells. Autoreactive T cells. T cells can attack directly the vessel wall.
Can you repeat the...
Yeah, I will repeat and I will make it concise also. So in the immune mediated mechanisms, which is basically the non-infectious, what will happen? Immune complexes will be formed. One, and these will attack the vessel. Or there are antibodies like ANCA antibodies or anti-endothelial cell antibodies which will attack the vessel wall. Or immune complexes antibodies, or there are autoreactive T cells which can attack the vessel wall. So three things will be there. Immune complexes, antibodies and autoreactive T cells.
Just what's the difference between the second and the third one?
The type of the endothelial body, the antibody is different, isn't it? Anti-endothelial cell antibody directed against the endothelium, and this is directly against the neutrophil. You got it? Both are antibody mediated, but the type of antibody is different. So we keep them separately. Now, how the immune complex mediated vasculitis occurs? The immune complexes may be formed in the circulation itself. They are formed in the blood and then they travel to different parts of the body and deposit in the vessels. Okay? So this is called circulating immune complex vasculitis. Second is in situ. In situ means it is present in the vessel itself. There is some antigen which is present, that antibody comes and attaches to that antigen, and there is in situ immune complex is formed and it causes the damage later on. Now, what is the diagnostic challenge? If you want to diagnose it, it is very, very difficult. Why? The immune complex mediated. The thing is that we don't know about the specific antigen. What is the specific antigen in the vessel wall? What is the specific? We don't know about that most of the times. And nature of the immune complexes is also not clear most of the time. Whether it is circulating or in situ. It is very difficult. Then in many cases, if you take the histology also, you will not find the immune complexes. Because the immune complexes may already have been degraded by the immune system. So it becomes difficult to diagnose. Then how you diagnose? Diagnosis is basically, how you diagnose? You diagnose it on the histopathology, depending upon which type of cells are there, granulomas are there or not. Then clinically, what are the vessels involved? Big vessels, small vessels. What is the predominant organ involved? Based on that, you will make a diagnosis. Because the immune complex may already have been removed. So even if you do the, the markers for the immunity or markers for detecting many antibodies or immune complexes, they will not yield much results. Clear? So this is the diagnostic challenge. And what are the examples of immune-mediated vasculitis? One is SLE.
Okay.
Type 3 hypersensitivity. Yes. Second is related to the SLE. In the experimental animals, we induce immune complex disease. That is known as Arthur's phenomena and serum sickness. Okay, this is for studying purposes. How the immune complexes are formed, how they attack the body. So this is experimental model. This is also an example of immune complex mediated vasculitis. So when you are, in the experiment, you are forming the immune complex. They attack the vessels of the animal, experimental animal. So this also is an example of immune complex associated vasculitis. Then drugs. People taking drugs. Normally I take drug, okay? Not that drug, medicine.
Yes.
Here, so drug hypersensitivity vasculitis. People take drug. Some people don't have the reaction. You take penicillin, no reaction. Somebody else takes, he has the reaction. Why? There is hypersensitivity. He is reacting abnormally against the drug. So sometimes how these antibodies are formed against the drugs? Basically this is the question. How they are formed? Look, there are mechanisms.
Yes.
Drugs can either act as hapten, and they can bind to some protein and cause the formation of a new antigen.
Yes.
Huh? Okay? Hapten itself is not an antigen. It has to bind to something.
Yes.
Or like this, act as hapten and bind to the host proteins, or act as foreign proteins directly. You got it? You take a drug, it acts as a foreign protein, causes the formation of antibody. Then the immune complexes are formed and deposit in the blood vessels. Or drugs act as haptens. They attach to some of the proteins and convert them into the antigens. Then the body starts reacting. The examples are of the hapten, penicillin, and of the foreign proteins is streptokinase. Streptokinase acts directly. Your body can form antibodies against the streptokinase directly. No antibodies directed against these, no antibodies against the drugs will be formed, whether through hapten mechanism or through foreign protein mechanism. And these antibodies will form the immune complexes by attaching to the antigens. And these immune complexes then will attack the blood vessel. So how the patient will behave? It can be a mild reaction or self-limiting. Mild reaction goes off.
Yes.
Or it can be very severe and even the person can die from it. So you have to be very, very careful. Especially if you are giving some injection and there is a hypersensitivity reaction. For example, penicillin. Yeah. No, not slowly. If there is hypersensitivity, first of all, if there is a hypersensitivity, no, I am not talking about testing. If hypersensitivity is there, somehow for the first dose the patient was saved, then you have to notify to the patient that already he should know and he should put a label in his pocket that I am allergic or hypersensitive to this drug. So it should never be given again.
Yes.
Otherwise, the second time, it can be much more dangerous. So, clinical manifestations are like this. It can be mild or it can be severe or even fatal. And skin lesions are most common. Taking a drug and you will have, the person will have the allergies. So, discontinuation of the drug will lead to, the symptoms will be gone if you discontinue the drug. But it depends how much hypersensitive the person is to the drug. If it is, higher grade hypersensitivity, then it should be avoided altogether. Now, there is vasculitis in the immune complex. We have vasculitis because of infections. Although we divide the vasculitis into infectious and non-infectious.
Yes.
But immune complex can be mediated through infections also. So this is the irony. There the infections are directly attacking. But here the antibodies are formed. Then they attack the bacteria. There is an immune complex formed. Okay? So antibody to microbial constituents form the immune complexes. These immune complexes then attack the vessel wall. But it is not a direct invasion of the vessel wall.
Yes.
Okay? So this is the difference. Where you find it? You find it in polyarteritis nodosa, PAN. Okay? The PAN, 30% of the patients, they are having hepatitis B infection. So what do you find? Hepatitis B antigen, hepatitis B antibody, immune complexes are there. Okay? And these complexes attack the blood vessels. Okay? So in PAN you will find with the hepatitis B infection. This is the example. So if you are asked immune complex mediated vasculitis but caused by infection, PAN is the example. Okay? Clear? Now the second thing is they can be mediated by immune complexes or can be mediated by antibodies. What are the antibodies? It is very, very important. Anti-neutrophilic cytoplasmic antibodies. It means this is not only against the neutrophil, but against something else also. Not only against the neutrophil, as the name indicates, but this is a heterogeneous group. Many antibodies are there, but two are most important. So these are autoantibodies which can attack the neutrophils, especially the enzymes in the primary granules of the neutrophils, or the monocytes, lysosomes, or the endothelial cells. So these are diverse group basically, but we will be talking only about two, which will be mainly attacking the neutrophils. So these are very useful for diagnosis. You can diagnose a person based on this because these are present in specific types. So you can diagnose them. The second prognosis also. Suppose you treat the patient and the patient comes again to you, he is behaving well, and you measure the ANCA levels. The ANCA levels have dropped. Okay? It means the patient is behaving nicely. So it is a good prognostic marker also. Diagnostic as well as prognostic. The third thing is, if you do not diagnose a prognosis, third thing is if the patient is not behaving properly, after the treatment, you measure the ANCA, you will find the ANCA raising. Like the ESR.
Yes.
ESR is up, the disease is not responding. ESR is down, the disease is responding. But here what happens? ANCA up, again, the disease is not responding. Down means the disease is responding.
Yes.
Your treatment is good. So this acts as a diagnostic as well as a prognostic marker. So what are the two types? Anti-proteinase 3, we call it as PR3 ANCA, and this was previously known as C ANCA. Okay, C ANCA, cytoplasmic ANCA. It is associated with Wagner's. So if you find this C ANCA, chances of Wagner's is very, very high. Okay, so C ANCA or PR3 ANCA associated with Wagner's granulomatosis. Second is anti-myeloperoxidase, MPO ANCA. It was previously called P ANCA. Okay, so it is associated with microscopic polyangiitis and Churg-Strauss syndrome. What are these? These three? Small vessel, very good. So these are small vessel vasculitis. So P ANCA or C ANCA, PR3 ANCA or NPO3 ANCA, they are associated with small vessel vasculitis. Small vessel vasculitis, not with the large vessel or medium.
Antiproteinase 3, we said it's with the granulomatosis. This also happened in the Churg stress because it also contains
Yeah, we will see. There is a little bit of overlap, but predominantly you will find in Wagner's. So it is directed against the enzyme myeloperoxidase. You got it? This antibody. You have the myeloperoxidase inside the neutrophils, and you have the proteinase 3 also inside the neutrophils. Huh? So these are directed against these enzymes. Now how they act? How the body is there, normally it is there, it is behaving very nicely, but suddenly it starts forming antibodies against the neutrophils, against the lysosomes of these monocytes. Why? Sometimes the person takes a drug or there is some infection. So the cross-reacting antibodies are formed. You got it? The antibodies which can react against the drug, which can react against the antigen, against the infection. And these can also act against the vessel wall. Or these can also act against the neutrophils, against the monocytes. Cross-reacting antibodies. Your body is forming antibody against the drug or against the bacteria, but it reacts against your own body, against the vessels, against the neutrophils. So what happens now? Or there is one more mechanism by which these antibodies can be formed. There is infection and inflammation. You know, whenever there is infection and inflammation, many mediators of inflammation will be secreted, like TNF. These upregulate the surface expression of PR3 and MPO. Normally, you have PR3 and MPO in the cytoplasm, in the granules of the neutrophil. This you have to understand. They are sequestered. They are not outside. They are inside the granules. You know what happens? There is surface expression. So they come to the membrane. When they come to the membrane, they will be exposed. Okay? So your body can form the antibodies against them. So two things are there: cross-reactive antibodies or increased surface expression of these molecules will lead to formation of the ANCA antibodies. Once ANCAs are formed, they will attack the neutrophils. How they attack? They activate the neutrophils. Once the neutrophils are activated, what they will do? They are reacting. They will secrete the reactive oxygen species. They will secrete the proteolytic enzymes. And what these enzymes or proteins or whatever proteinases or ROS will do? They can attack the vessels. They can attack the vessels.
Attack or activate the neutrophils.
This is the move. Attacking means the activating. Yes. You got it. Attacking means activating. Like thyroid stimulating antibodies.
Yes.
Yes. You got it. They activate basically, yeah. They will increase secretion.
Mimic.
Yeah. They mimic. So here these ANCAs also activate the neutrophils, causing them to release the reactive oxygen species and the proteolytic enzymes which cause the endothelial injury. But again the problem is there. Most of these vasculites which are associated with ANCA, they are posse-immune. Means you will not find immune complexes or antibody or complement. Why?
They are outside the granules.
Yeah, this is one of the reasons, yeah. Because these granules basically, they are inside and ANCAs are directed against the neutrophils, against the granules of the neutrophils. So you will not find much of these ANCA antibodies or immune complexes in the tissues. Now we move to the specific antibodies, these vasculites. The first one among the large vessel. What is the name?
Takayashi.
One is Takayasu,
Yes.
another is giant cell.
Giant cell.
Basically, in both you will find granulomas. In both the large cell, you will find granuloma, and you will find the giant cells. In both. But here you call it as giant cell or temporal arterites. Giant cell because it contains giant cells, and temporal because it mainly involves the superficial temporal artery. Here, I will show you the diagram also. So this is the most common form of vasculites in the elderly. In the elderly, okay? In the developed countries. So most common form of vasculites in the elderly, present above age of 50 years. So above 50 you will say giant cell arterites. What you will find? You will find a granulomatous inflammation. Granulomatous inflammation which is involving large to medium sized. Even the small size arteries. So there is overlap. But predominantly it will be affecting the large. Okay? But it can affect the medium and the small sized arteries. And mainly those supplying the head. Those supplying the head. So this is the difference. Those supplying the head. Especially the temporal arteries. But you can have the other arteries which can be affected, like vertebral arteries, like ophthalmic arteries, and like the aorta also. So if it involves the aorta, we call it as giant cell aortites. So you have the big vessels, you have the aorta, you have the vessels arising from the aorta, vertebral arteries are there, then you have the ophthalmic arteries, especially related to this area.
Yes.
This area, superficial temporal. So it can involve those arteries. And it can involve the other arteries also, the larger ones. But these are the predominant modes of involvement. How this occurs? Whenever you find a granuloma, how the granulomas are formed?
Immune cell.
How? What is the mechanism?
When they cannot kill the.
How? Yeah, that is good. What is the mechanism? Which type of hypersensitivity?
Oh,
Yeah.
oh.
So it is a T cell mediated hypersensitivity or type 4 hypersensitivity, isn't it? Which will lead to the formation of the granuloma. So this is a T cell mediated immune response. So if you have the question, it is T cell mediated because granuloma is there, it will be mediated by the type 4 or T cell mediated hypersensitivity. So T cells, once they react against a vessel wall antigen, they will cause the formation of cytokines. So these cytokines are also involved because T cells, they cannot act directly. They have to form the cytokines like tumor necrosis factor. And sometimes you will find the anti-endothelial cell antibodies. But the predominant mode of involvement is T cell mediated, which is the first one. So this is the pathogenesis. How you will find the patient? Remember, once and for all, in all the cases of vasculitis, you will have non-specific symptoms, which are not specific, like fever, malaise, weight loss. These are non-specific. They can be present in any vasculitis. Second is the symptoms which are typically present in a vasculitis, like it is involving this area. So you will have something wrong here. You will have headache, severe headache, okay? Facial pain in the area of the face. Facial pain or headache, and this headache will be along the superficial temporal artery here. Here you will have severe headache in this area. And then if the ophthalmic artery is involved, you will have the eye signs, like it can even lead to sudden and permanent blindness. So this is the importance